just want to briefly introduce the team. On my left is Mihai Cocoi. If you've not heard of him, probably you will, because apart from an excellent operator, he's also a very talented artist. He made all these drawings from the new CTO Toolbox book. Probably Mihailo Kovacic showed the book. I believe he showed the book to you yesterday. Myself is Alexandru Achim. From the nursing side, we have Cristina, Emanuel, and Mariana. We also have intensive care support, Dr. Lucia, Timotei, and Dana, so a really large team. And the video transmission is made possible by Bogdan. So a really large and young team. We are very happy and honored to be with you. I believe we have a nice case. It's not too easy, not too difficult. I suggest I give the word to Mihai to show you the case, the patient, and then we will show you the setup, the images from today, and then we can have a discussion, and then we'll take it from there.
So we have on the table a 51-year-old male, very active farmer, former smoker with mixed dyslipidemia, no hypertension, with a BMI of 25. He first presented to our hospital in May 2024 with an anterior ST elevation myocardial infarction with a late presentation. At that moment, his transthoracic echography showed a left ventricular ejection fraction of 35% and akinesia of the anterior territory, also inferior and lateral hyperkinesia. Emergency coronary angiography was performed, which showed a subtotal lesion of the proximal LAD with poor distal flow. The lesion was fixed with a 3.5 by 23 DES post-dilated with a 4.0 mm balloon. He also had a CTO of the right coronary artery and was scheduled for re-evaluation and PCI of the CTO of the RCA 3 months later. So here we are 3 months later. The patient is still symptomatic with a class 2 angina with anterior territory which are scarred, and at low dose dobutamine the inferior and lateral territories are viable. Therefore, decision to continue with PCI of the RCA CTO was made. So what we do in our CTO patients, we try to overlay the initial shots of the coronary tree in order to recreate a virtual dual setup shot, and based on this we create some graphics to evaluate the CTO following the JCTO score. So for our particular patient, we have a proximal cap which is bland, which means JCTO score 1, a length of more than 20 millimeters, which means JCTO score of 2, tortuosity, which means JCTO score of 3, and if we can assess better at the dual setup shot from today, if we have calcium on the way, that would mean a JCTO score of 4. There are some particular elements to this case. First of all, there's a island within the body of the CTO, which might suggest microchannels or even a residual channel up to the island. Also, the distal cap is at the crux. We don't know if the real distal cap of the CTO is at the crux or the crux is underperfused and dormant. And we also have a stent in the proximal LAD, which jails some proximal septals, but leaves the big ones, which are interventional, in order to facilitate access to them today.
Okay, so the
I will let you
two initial setup shots. This is the LAO cranial shot, LAO. So basically, we have a.
But first,
the
maybe
setup is
we tell a few words about the setup access.
Standard radial 6 French for the left system with the EVO 3.5 and the BMW wire in the distal LAD for protection. And on the groin, we have a 7 French Amplatz left 1 with a workhorse Cyan Blue and a Corsair Pro 135 in the proximal RCA. So with these, we did the dual setup shot on the guiding catheter, so you can appreciate the proximal cap of the CTO, which seems to be blunt, but however, you can now see at the level of the body that it seems to be a residual channel, or at least up to the island in the body of the CTO. And then we also have the REO setup shots, which actually show a very big septal collateral filling from the left side. The initial trajectory of that septal might be a bit tricky because we don't know if it comes out of the other septal or it just comes out straight from the LAD. And we also can see at maybe 4 or 5 o'clock another septal which is smaller but with a pretty straight segment that goes straight from the LAD into the PDA. So these are the initial setup shots. Another thing which is worth mentioning is that in the 3 months follow-up time, the patient's ejection fraction did not improve that much, so he is again at 35 ejection fraction, increasing with dobutamine to 40, and his left ventricle started to dilate a bit, so he is at the moment on optimal medical therapy as far as we can increase the doses, because he is normotensive with a blood pressure of 110 by 75 at the moment. So this is the case, and if we want, we can stop now and maybe discuss strategies and address questions if you have.
Yeah, I just want to make a short comment and then I will let you talk. The occlusion is unfortunately up to the crux, so we thought there is like the distal cap of the occlusion is more proximal, but it's not. It's exactly in front of the crux. This is a bit complicated for us because we need to save both branches of the right coronary. And also what's new for us is this large, big septal, almost like an epicardial, filling the posterior descending artery. This is like a juicy septal which we could use, but as you can see, the takeoff of this septal is a bit complicated. Is a bit ambiguous and angulated. We don't know if this second septal has an origin from the LAD or actually from this first septal. So this probably we need to, if we need to go retrograde, we need to figure out.
So I think it's a great case, and probably the real CTO is in the distal RCA. Proximal part is probably a recanalized or a microchannel based segment. And as you rightly mentioned, I think the challenge is going to be at the bifurcation when you enter the distal cap. So please go ahead. Any other comments?
You have taken the Pillar XT or Pillar FC. So Pillar XT is taken.
That's the question. That's what we want to find out from you. We didn't do anything yet. We just have the microcatheter in place, and we will discuss now about the strategies, which wire, which antegrade wire, and so on. So we are curious about your opinion.
So this is live now, if you can see us. The wire that is inside the microcatheter is just actually a cyan blue. So it's nothing. Just
what do you think about the strategy of the CTO? The CTO is like a medium complexity. It's not too easy, not too difficult. I think the trickiest part of the CTO is actually to get the both distal branches. What do you think?
Doctor, this is Dr. Rao from India.
Hi.
The lesion, actually, it's a long segment disease with a tight lesion beyond the bend. That's the real CTO here.
Exactly.
And good point is good retrograde filling of the PD beyond the bifurcation. The septal which is feeding is branching at the origin. But there's certain good point. There's a neo channel till the true CTO short segment is there. That's I think you can have an antegrade approach with any of the micro catheters with a polymer jacket wire till the CTO segment. But the short segment CTO may need escalation of the wire escalation at this juncture. And once beyond the bend, we have to de-escalate the wire. We don't know at the bifurcation there is any other segment of the CTO that has to be seen. So
we don't know that, but we will see.
The approach where wire escalation, de-escalation technique is the choice in my view.
Okay, excuse me. And so actually this patient is a complex high risk indicated patient. I totally agree with this indication. And how to manage this procedure? Okay, and already the Dr. Lau mentioned about this CTO exit, how a very important bifurcation. So additionally, I'd like to mention about this. So this RCA4PL, RCPL is there there's no connection to the collaterals. So I mean,
Yeah.
if created a hematoma after bifurcation, a CTO distal part, so that we have the risks that lost their RCPL. So maybe in this time there should be occurred a very severe ischemia, I am afraid of. So, and so actually so this time is the first attempt. So the one time that we directly try to develop the antegrade. So actually CTO length is here, that make quite short. And already Dr. Lau mentioned about this. And but if we the performing the parallel technique and something that some kind of the intentional antibody wiring, that we have the risks that created the hematoma at the CTO distal part, and sometimes maybe it's just the occurring the severe ischemia at the posterolateral air layer. And if the fail to the stick, the one-time stick from the antegrade, and we would like move to the later grade using the very nice septal channel. That's why we have to the keep in this important bifurcation.
So that's a good point. So we were our initial strategy was, of course, to start with antegrade wire escalation, antegrade wiring. We respect the hybrid protocol, and if we get to the crux, it would be, as you mentioned, ideal to get into the PL, not necessarily PD, because PD feels good retrogradely, and we have retrograde options to recover that branch if we lose it, and if we get hematoma. But we will see how it goes.
Are there any more opinions in the panel?
Thanks.
Yeah, please go ahead. We'll watch. Actually, the distal cap probably is more proximal to the crux because we can see a little
probably probably it's dormant and hypoperfused, so that would be a good choice. But I guess that if we manage to get a wire through and maybe predilate a bit, we can IVUS it, and then we can assess very easily to see if the actual crux is free of disease or not. I mean, it's in a CTO body or not. Yeah.
So what wire would you begin with?
Actually, speaking, there is a micro channel. I should do the XT, which is preferable because the micro channel is there.
Yeah. Actually, this is an excellent suggestion. We will also use Fielder XTA for the beginning of the antegrade wire escalation. It's a polymer jacket taper tip 1 gram tip load wire. We use it like this because we believe there is a microchannel, and we want to follow that microchannel and actually not go subintimal with a higher tip load wire, and then we will take it from there. So now we have a micro catheter Corsair, and this is Fielder XTA. We didn't do anything. We just waited for you to see everything live.
Okay, and we would like to discuss about in this situation for the negotiate this like a micro channel, and we have two options. One is here XTA, the other is XTR, which
exactly
which is better for the distal lesion.
For the distal lesion?
Probably for the proximal lesion, the XTR is better because it's less tip load and it follows the microchannel. For the distal lesion, probably the XTA is better, so that's why we
guiding. I think in your guiding needs more support.
Yeah.
As you can see already, we have the Amplatz left catheter going up.
Yeah, we will fix the position.
Thing is, the right coronary is diseased up to the ostium, so if we intubate it, we lose pressure. We have pressure dumping, so we intentionally stayed with the catheter outside. That probably we need to go in once we.
Well, I went in with the.
But now
the Amplatz left one.
But now the pressure is good, Mihai. So I think we are steady. We actually thought about changing the catheter, but to be honest, in CTO we rarely use Judkins right. Most of the cases we use Amplatz. Even if we have a bit of pressure dampening, you can still manage.
And do you have option about anchor and anchoring?
Sorry?
Branch, and do you have the option in there for the branch anchoring?
Yeah, we do have. There's a big branch coming more proximal to the cap, the proximal cap of the CTO, which we can anchor if we need to.
Okay.
But at the moment we are not pushing anything, just probing to see if we get that microchannel, to see if we go somewhere. You see now it seems to, the wire seems to go in a direction which is probably not that good. So maybe
So
it's
the
a
idea is not
branch.
to rush, not to mess up the microchannels. Take your time. Spin more the wire than push it. If not, maybe there is no microchannel up there. I'm not sure if you can see the reference imaging. There is a microchannel, then there is a bit with of ambiguity. We don't see too much, and then there is this island. So if we actually don't have a microchannel, maybe we change the strategy.
Yeah. Maybe we
But
have.
you know, every technique deserves 5 minutes. It's always good to give 5 minutes, not more. If you don't succeed in 5 minutes, you change the strategy. It's always good to change the strategy. There are also some bridging collaterals where you have the tip of the filter, Mihai. So probably this is also a problem.
Yeah. Yeah, but we're not pushing. We don't want to create a knuckle with the filter. So
I think now it looks much better.
Whenever
I think
it
now
bends,
it looks much better. Yes. Yes.
Whenever it bends, we will slowly advance a bit the tip of the MC, so we give a little more power to the tip.
Another important aspect is that the distance from the tip of the guide wire up to the tip of the microcatheter is directly proportional with the tip load. So actually, if you follow with the microcatheter close to the wire, you increase the tip load of the XTA almost up to confianza. So right now we don't have 1 gram, we have much more if you follow with the microcatheter.
You're better placed now, better.
Yeah, it is.
So what do you think now? The wire is behaving a bit strange. As you can see.
A little bit.
Yeah, I think we're good here. I think
at least we are in the vessel. We don't know where, but we are in the structure of the vessel.
The problem is, so we don't know if we're intraplaque or extraplaque, right? But we know we're in the vessel architecture for 2 reasons. First of all, this is a filter, which is a polymer jacketed wire, and they tend to stay in the vessel architecture. And secondly, it seems to follow the curve of the vessel. We have the reference image very close to us. So yeah.
As well.
The problem is that we cannot inject antegradely at this point because we have the microcatheter wedged in the proximal cap of the CTO, which creates dampening, and we do not see antegrade feeling. So if we need to, if we want to inject antegradely, there are 2 options. We can try to advance the microcatheter and inject through the tip of the microcatheter, but that will automatically transform hydraulic dissection, which will change our strategy completely. Or we can take out a bit the microcatheter, the tip of the microcatheter, and inject to see if the wire is good. So these are our options, I think.
But the question is, Mihai, do we need to inject at this point?
No, I don't think.
Yes. This group of patients, actually, we want to use the Corsair usually better. Which microcatheter?
This is a Corsair Pro.
Corsair Pro 135, so the standard Corsair.
Okay.
Right now, I suggest you follow with the microcatheter. I believe we are subintimal from the behavior of the filter, and then maybe we try.
There's no harm UML antegrade at this stage because you did not do much wire manipulation, and
and we will try to be as gentle as possible. And keep in mind, even if this is a microchannel, we keep in mind we didn't actually.
How is it feel with the wire? You feel
the tactile. Yeah, it's. I think now we are in the island, so now it's moving freely. But at this point, you can see it here where it starts to bend. I'm not going to push anymore.
Let me.
When it starts to bend, you see this is just a bit of tension, not like a subintimal type of tension, but just like a true proximal cap tension.
Here you put the Gaia now at this juncture because you need one-to-one manipulation here.
Yeah, probably. Yeah.
This is a good suggestion to escalate at this point.
I will just put the microcatheter down. So very gentle movements. I open the valve. I rotate clockwise or counterclockwise. In this case, I rotated clockwise and just let the microcatheter go in by itself. I didn't do anything.
You can see the micro goes very well. It's a,
so the microcatheter
very
is down.
versatile microcatheter is from Asahi. Normally, you can also clockwise and anti-clockwise it. The company says more anti-clockwise and less clockwise.
So at this moment, I don't want to continue with the Fielder XTA. So we have two options. Either we escalate to a polymer jacketed wire non-tapered with a higher tip load, like a Gladius EX, for example.
Or we take a directional wire.
We go with, and this is actually our suggestion, and our plan is to go with a Gaia next to.
Yeah,
the problem is the directional wire can also go outside the vessel.
Yeah.
If we take the polymer jacket, we are
what do you think?
more sure to stay within the if we take now the Gaia and then we de-escalate to the polymer jacket, we cannot do that anymore because we already created a channel with the Gaia and the polymer jacket which will follow that channel. So my opinion now is actually don't step too much to the Gaia and maybe try with the Gladius first and then as a third option use the Gaia because of this reason.
Okay, and for me, so in this time we have to change the strategy, guidewire strategy. Okay, and up to the island, okay, and we can use a tapered polymer jacket guidewire with a. But after that, the CTO exit, here is the actual CTO. Maybe we have to do the intentional guidewire manipulating for the stick, the actual bifurcation at the CTO distal part. And actually, so this CTO region is not so long. So maybe for me, the suitable for the performing the intentional guidewire manipulating. So and how to say that? The guidewire concept is here, the maneuverability is best. Easier for me, the Gaia next is best.
Yeah. Okay, so let's vote if you want. Do you want to take the Gaia next? We have the Gaia next 2, Gaia next 3, Gaia standard,
or the Gladius.
2, Gaia standard 3, or the Gladius EX or MG. Our personal opinion, I mean, my personal opinion would be to go for Gaia next 2. But if you want, we can try with the Gladius, no problem.
Yeah, maybe we need their penetration efficacy. That we need the same as their Gaia next 2.
Gaia next to the retrograde injections, you can manipulate.
Yes, and usually that this like a bifurcation CTO exit is very hard. So maybe we need the access Gaia next 2 around.
Okay.
As you can see, the island goes up to the horizontal segment of the distal horizontal segment. So right now we are with the wire here, exactly in front of that island. Do you think now the wire is in that island or it's subintimal? Or it doesn't matter?
It feels, I mean, tactile feedback, it feels I feel it's free. It feels in the island.
Okay.
And it really doesn't matter at this point because.
Okay, that's a very good point. Gaia second?
Gaia next second.
Gaia next second.
And next.
Sorry?
Why you are preferring next instead of Gaia 2?
Sorry?
Why you are taking the Gaia next rather than the Gaia 2 first?
Well, first of all, we like the Gaia family. We like the Gaia next family as well. The Gaia next 2 has a 4-gram tip load compared to 3.5, so a bit higher. Their both tip loads are uncoated. The Gaia next family has the tip load which is a microcone different from the Gaia, and the Siontech technology of the Gaia next 2 is with the X strand, which means that actually the spring coils are created out of 7 different loops wrapped around the coils.
Like
7 wires.
ropes.
So that means that it will give us good directional control, good backup, and if there are some calcification on the way, due to the tip of the microcone of the Gaia next 2, it won't get stuck, as you happen sometimes if there's a chunk of calcium in the CTO. Sometimes directional wires can get stuck, and when you put them out, the microcatheter plunges in.
Yeah.
So the Gaia next
you know that movement, and then you ruin the Gaia.
So the Gaia next 2 probably is a choice. Plus, and we we want to try it as much as possible because we don't have it.
Exactly. That's also a good reason we just got it recently, and we want to try the you know, they
What
say
is
the control is much better with the Gaia Next.
What is the
Because-
expected age of this CTO? Right.
We don't know. Out of the patient's history, at least 6 years, but we can't tell. The patient came to our clinic like 3 months ago, so definitely 3 months. But coming back to his history, probably around 6 years or something like that.
Do you want to torque?
Yeah.
With Gaia Next, especially with Gaia Next, I think it's better to use not to spin it too much,
I'm not spinning it at all.
but use the torquer.
I'm trying to grab tissue if I can. And
See here, it's pretty free.
it goes somewhere, maybe a branch.
The wire is free here. And now tell us what you feel.
I feel no, it is free, but I feel some resistance here, so I have no problems in advancing a bit the microcatheter next to it, and at the same time rearranging my left side guiding catheter to offer some support. Okay.
I remember.
And how about tactile feeling? You feel some.
Yeah, there is. I'm grabbing tissue. So the tactile feeling is that there is tissue grabbing right now. Now, ideally, I don't want to bend the tip of the Gaia, and whenever it bends, I try to pull back a bit and then slowly redirect in order to find a way, find a
Now I
path.
think you found something.
I don't know. So I'm slowly advancing. I'm gentle spinning. I'm spinning gently with the right hand to 30 to 45 degrees, and slowly pushing forward, putting forward pressure with the left hand, not pushing very hard, and see where it goes. And we also is a good idea to move in the same projection that we have
Cranial, yeah, like this.
Done the setup shot in, so we know we are on the same path. And it seems to be the same path, actually. You don't see the reference images, but we have them side by side, and it seems to be going in the good direction. In a good direction,
close to the crux. So I think from now on you will feel the distal cap if
I
you
think
feel
from
it.
now on we stop and do a retro injection.
Yeah, okay.
Maybe this time is there for the checking the contrast.
Yeah, that's what we're doing. Okay,
go.
Alex, go. Ready? Go. Oh, so we are still far.
Still a bit to go.
And I think we're out.
I think we're out, yeah, because we can see, I'm not sure if you can see the quality of the angio, but we can see that the calcium is higher on the upper side of the guide wire.
Yeah. And I think
both the vessel are big. Both PDA and PLV is big size.
But then just continue and see where it goes. If not, we
I don't think it goes.
We do the technique of Mihalo, maybe
SSDR.
SSDR. We just poke some holes and then de-escalate to a gladius. Should I do again? One control? And then you move the wire.
I don't think we.
But probably we are somewhere.
I think we're out.
Somewhere.
I think we're out. But we can try
in the La Land. But let's see.
While Alex does a retro injection, I will try to move the wire to see if it goes anywhere. No.
Yes.
Okay. So we know.
Sub-integral.
Yeah.
So what would you do now? Let us show the images and then.
Oh, sorry. Okay.
What would you do now?
I think he should go a retrograde approach and keep it there, and that's safe.
We are already like 10 minutes in the antegrade. We can maybe invest another 5 to
redirect.
We can also like do a parallel wire technique here on this.
Yes.
Yeah, parallel wire. The problem with parallel wiring in this area is that it will create big hematoma in the crux, and it will most likely damage the crux, and we don't want to do that, right? So
exactly, we are very close to the crux now, and if we play too much with this guy close to the crux, it's exactly like you said at the beginning. We can create hematoma here, and
yes. So
I'm not sure if you can see the pressure now. It's a bit dampening, so we always need to be careful with this amplats left when it goes inside.
I rearrange it. We lose a bit of the backup support, but it doesn't matter at the moment.
So let's try to find another way, and if not, maybe we go retrograde.
See, so this is the problem. The tip of the Gaia just grabbed some
maybe you do
calcium.
SSDR a bit.
I cannot move the tip of the Gaia now, so I have to very closely keep the microcatheter in place while pulling out the Gaia, because the Gaia was stuck. Yeah, it was the tip of the Gaia was stuck in a calcium.
Can you pull it back, the Gaia?
Yeah, I did it. Okay, so what I will try to do is actually pull back the microcatheter a bit and try to redirect from more proximal part.
You can pull the microcatheter more, then retry.
Yeah, that's what I'm doing right now.
But we need to be slow to do that slow, because we are also outside with the guiding catheter, and the danger now is to lose everything.
No, because I'm not putting a lot of pressure.
As you can see, or probably you see or not, the calcium is a bit higher, is above this guide wire. So we need to go above.
Yeah.
Here is I think, I believe, where you were initially.
Yeah.
Yeah, here and a little bit we can see the crossfire part.
Yeah.
And it's calcium. It's much more calcium than we thought.
Yeah, it is.
Both PD and PLV nearly equal size. Your intention preferable to go to the PLV. It is nearly straight.
Yeah, that's our intention, and also the PL is not collateralized by the left. So the PD we can get from the left, but the PL no. So we don't want to lose it at this moment. Maybe nothing happens, but if it creates ischemia, it will be a big ischemia. Keep in mind the patient has a 35 ejection fraction and the recent myocardial infarction on the anterior territory, which creates
exactly. That's another discussion. If we take the big septal, maybe we induce ischemia.
Yeah.
And we also lose visibility. We don't see too much retrograde if we take the big.
That's what I was saying, that we actually have a distal septal, which is far less big. It's very, very small, but I think we can get that without creating ischemia and without losing retrograde feeling. So what I'm doing.
Here EF is low and don't want to give too much contrast. I think at this stage go retrograde, because it's a bifurcation lesion, not to miss the two big branches. That will be more easy job for you to do a cross cut and externalize.
Yeah. So what I'm doing now is actually I'm trying to, so we don't want to parallel wire here. We don't want to, obviously Stingray is out of the question, being the distal cap at the crux, and we don't want to re-enter and cause hematoma. I'm trying to do Mihailo Kovac's technique, which is SSDR, which is a stiff wire penetration and de-escalation and re-entry, which actually means that we take a penetrative guide wire, usually bigger than this one, a Gaia 3 or a Confianza 12, and you just poke around and you do like 2 or 3 holes in a 330 degree fashion, and you keep the microcatheter tip distally to what you're doing, proximally to what you're doing, sorry. And then you take out the Gaia 2 and you de-escalate to a polymer jacketed medium deep load wire,
like a pilot or Gladius.
Gladius CX. And we'll try to see if the Gladius flies through the holes we created or not. And if that doesn't go, we'll leave the Gladius there with a knuckle, and then we'll go retro, if it's okay with you.
Gladius EX. Maybe you go a bit more anterior.
Yeah, I will. Problem is that we need to take the microcatheter maybe even further back. So we have a nice trajectory towards the RCA.
Here it's different.
Yeah,
you're grabbing some tissue.
Yeah.
Yeah, looks like difficult to control.
It is. Yeah.
But
maybe by your motion, the automatically making their knuckle shape, maybe going to the extra plug already.
Yeah, that's what we're trying to do. We're de-escalating to a Gladius and try to extra plug it.
And how about the patient renal function?
Yeah.
It's okay.
It's good. Biologically he's perfect. Nothing abnormal. Plus we checked his LVPD before the case and it's 9, so it's good. He's compensated.
Okay.
Because we started at the beginning having a low ejection fraction, a recent myocardial infarction, a CTO of the right coronary artery, then maybe left ventricular support might be an idea, but we don't have arguments for it. So the patient is stable and asymptomatic.
Exactly. I mean, what we usually do, we measure the LVDP pressure at the beginning of the procedure, and if the LVDP is normal, then we don't use mechanical support. I'm not sure what's the situation in India. We don't have Impella in Romania, so
no, we don't.
We just have IVAC and the good old EABP.
And ECMO.
And of course ECMO, but this is, I think, it's an overkill.
Yeah.
Are you planning more?
So now what I'm doing is actually taking the Gladius EX and I'm just spinning and not doing anything else, just spinning. And just spin.
See the tip of the
spin and spin.
Tip of the wire. It's dancing a bit weird. This is my opinion. It doesn't dance with the vessel.
Yeah, we
will do now a retrograde injection, but probably from the behavior of the wire, it is somewhere in the
out. Yeah.
La La Land. Yeah.
So it is far out. Okay. Okay. So it's far out just from the beginning. It's out.
Yeah, and basically it is like a polymer jacket and don't have the good maneuverability.
Yeah. But it's basically going.
Now it's a bit.
It's going blind, but maybe here. Yeah, maybe here. We did some. So again, we poked some holes with the guy next to, right? So he has a 4-gram tip load, and now I just pinned it to see if it goes somewhere. And it didn't. It didn't. Okay.
So maybe this is the timing to switch to the retrograde.
Yeah, we switch to the retrograde now. So we leave here everything in place, I think.
Yes, I think we leave this like this, the micro and the Gladius.
Everything in place, and then we have
the hematoma extends, you will lose the bifurcation point. So better at this go retrograde, do a reverse cut that's safe and faster.
Yes. Yeah. That's what we're trying to do. Yeah.
And we already almost finished the antegrade preparation for the reverse cut.
Already, yes, exactly. But we leave the wire inside, the microcatheter inside, so we don't we don't create a lot of hematoma in the subintimal space. I will also take back the unplugged F1.
Turnpike LP.
turnpike LP. Yeah. So we have equal blood pressures both on the right and the left, so we don't have ischemia on the right while working on the left. And we will do a separate injection for the left to decide on which septal to go in. I would rather go through the distal septal, but we can also try to poke and try to see if we go into the proximal one. We'll do another injection just for the audience. Yeah, so I have to cannulate a little better. Plus, there was a saline solution in the. Okay, so the proximal LAD has a 3.0 pulse dilated with 4.0 stent. It jails some septals, but nothing significant. Yeah, and this is the. These are our options.
In this point, if you do the IVAS, that can help you to cross the vision.
I think this image is clear. This one.
Yeah, we can.
This one. So just to get the idea what we are thinking about, if we take this large septal, we have two issues. One, the takeoff is a bit complicated, and second, we might create ischemia, and this is important in his heart failure condition. So maybe we try to go more distally. I'm not sure if you see more towards the apical part of the LAD. There is this 90-degree takeoff to septal, which has a good connection also with the PD.
Yeah.
And it's not very tortuous. It's more distal. This is not very convenient, but it's a friendlier, maybe safer with.
I think it's doable. I think it's doable that, and we don't lose retrograde feeling because the big juicy septal is still patent. And if that fails, we can go back to the big juicy septal. What do you guys think?
Let me put you this reference, and then I give you
ACT
blue.
We are 420 with the ACT.
And we gave 3 more thousand.
3 more thousand heparin.
So we are
good with the ACT.
So this is the cyan blue from the beginning with the turnpike LP.
90-degree bend.
The bend from the beginning. But you just go with this and then we exchange. You go inside and then we exchange.
You have to manipulate it, please. It's in the diagonal, no problem. Yeah, that was it.
that was the step.
Yeah, yeah.
Then I hold the wire.
Yeah, yeah. Keep it steady here.
And like this, not more.
Yeah.
I'm not sure. Up. I think this is it.
I think this is it. 1 second. So I give a small puff.
No.
No, this
more
is not it.
No, not more proximal.
More proximal. Yeah.
We are too RAO, and then we get too much X-ray. And we.
It's not that much proximal, but it is.
This is better.
I think the tip of the cyan is a little bit.
The tip of the cyan blue is not very good, but maybe you can manage just to go inside. And whenever you want, I give you a bit of contrast.
A puff, only a small puff.
The one above?
Yeah.
I think? Yeah. Let's try, maybe it goes. If not, we change the wire.
We have to change to
the wire is
bend.
ruined, but maybe it goes.
Yeah. You have to change to a better bend because this is not a good bend.
And also, maybe you go a bit back with the micro. That helps.
No, it's here. It's here.
No.
No. Okay. Can we get another?
Another Sion blue, or you wanna?
Sion blue.
Another Sion blue.
Then we exchange to black if we need to.
Better we take the more proximal one rather than going too distal. It will be difficult navigating the microcatheter.
Yeah, we will try 1 second to see if we go in. If not, we will switch immediately to the proximal one. Okay.
Apical collateral, your chance of perforation there, you should use the caravel. Just just reduce the perforation, the apical collateral.
Yeah, we're not.
I
We're
didn't keep any band.
we're not trying to go to the apical. We're still trying to keep it in the septals.
You see there's, but also the takeoff is a bit. I think it's not so
friendly.
Not so friendly. And then there is another one more apical, but then we go to maybe we go to this.
Apical, no.
Okay.
I think this is it. I think this is it.
Is it?
I don't know, but we can put the microcatheter in and we can actually tip inject if we need to. Yeah. I think we're losing time here. Let's try to go to the proximal. What do you say? What do you guys say?
Yeah.
So the proximal is to change the bend of the wire.
Excuse me, and please explain about your system, the guide wire, and the microcatheter with your concept.
The guide wire is a EBO 3.56 French from the right radial. The microcatheter is third pike LP 150.
Third pike, okay.
Third pike LP, and the wire here is just a workhorse, the cyan blue, the same cyan blue we used from the beginning. But we changed the band a little so to see if we get into the septals more easily.
Okay, you are somewhere.
To see where we're going.
Proximal.
It's too proximal.
But should we take it? No.
I don't think.
No.
No, we'll go for the bigger one.
Okay, this is it. This is it.
Yeah. Yeah, but you see,
if we take this one,
I don't know if it connects.
Should we do a dip injection?
Yeah.
And see?
Yeah, we can.
Because the other one is more it's bigger, but if we can manage this one, maybe we don't create ischemia. It's just an idea.
Yeah. Yeah. Maybe leave it like this, the tip and tip inject. What do you say?
Yeah.
Blue.
Milliliter syringe. Do we have?
Yeah, we do. 1 second. So we are aspirating until we at least 30 seconds until we have back bleed and good blood flow in the syringe. I don't know if you can see it here. And then we take a 2 milliliter syringe.
Do we have one?
Yeah, we had one. 2 milliliter syringe,
2 milliliter
please.
syringe.
Full of contrast. We inject contrast slowly under fluoro, and when we see contrast filling, we do China. Then we flush with saline.
There is a connection, but to the PL, huh? Or
no,
there is also to see. No, you see the other one.
No worries, because we will see now when we inject the second one.
But you can see actually that the PD is connected. See?
Yeah.
To the other one.
So the PD is connected to the other one. We need to pull back
And
the
this one is connected to
microcatheter.
the PL.
Yeah, we need to pull back the microcatheter and try to find the second one, the one which has a bend at the tip.
Okay.
Okay.
See the bifurcation.
could have done Sasuke wiring, we could have done sidecar wiring, but just
But because of the IVUS, we
because of
decided
the
just to go like a parallel workhorse wire, and this is actually another Sion blue.
This is another Sion blue
into the PL.
And
now,
we checked antegradely now because we knew we could inject, and you can see where the problem is.
IVUS, again, we knew that we are allowed to inject. We don't have too much hematoma, and we have 2 wires now, and everything is protected.
And then we checked the left system and took it out, and now we are in this position. And yeah, I think we're preparing for a bit of shockwave in the right.
Tip-in is very useful, either in the guiding or in the.
Yeah, exactly. We did it 7 times now, so it works.
It is a proof of concept that the tip-in works when you have struggle.
But we had
your retrograde microcatheter up, and then you're not able to externalize.
We had no other choices at the moment. We couldn't put the retro microcatheter up to externalize, and we couldn't put the.
Big hand to Dr. Team from Romania for the excellent typical case, long segment CTO with and
it was
hybrid technique, antegrade, then going to retrograde, a tip in many techniques used, and finally they will stent it. It's not an issue. I think they maintained the ACT, they are done in right time and good result with the EF, low EF, difficult case. Congrats. Thank you.
Yeah, thank you very much.
It was a pleasure to be with you.
Thank you.
And see you. We are now continuing the PCI with shockwave.
See you next meeting. The plan is to continue with shockwave on the concentric calcium, do an IVUS run to confirm that we cracked the calcium, and then stent the vessel.
Thank you.